Welcome to Assimilate Fireside Chat by Medvarsity, Episode 3. I'm Dr. Suparna, and today we'll be exploring the topic public expectations and misunderstandings about critical care. Today, our special guest is Dr. V. Rakesh, who is a leading doctor and ECMO specialist at GMK Hospitals, Hyderabad. He is also the CEO of Varahi Care Services. Welcome, Dr. Rakesh. Thank you for joining us. Let's dive right in. The first question I have for you is, could you explain what critical care means and why is it considered a unique field in healthcare?
First of all, thank you so much, Suparna, and thank you, Medvarsity, for involving me in this program, especially an innovative thought to educate all the viewers here. So, coming back to your question, what is meant by critical care medicine? As I'm telling, it's not a new field or it's not a new term that has been coined. It's there since the human race has been started. So, wherein all our rishis who are there, they used to treat all the patients keeping in a particular place. Say, for example, all the patients who were suffering from a stroke were kept in a particular place and they used to treat them. And patients suffering from infections, they used to keep them in a place which is bounded by water and all, so that no other person can come inside, no other person can go out without getting treated. So in a way, they are isolating the patients, keeping them in a particular place so that all their needs in terms of medicine has been met. The same concept has been copied by the modern generation, wherein the hospitals are creating a particular place for a critical care or a particular number of beds for a critical care department. So wherein we used to keep all the patients suffering from critical illness diseases or patients who are trying to fight with a life and death situation. So we used to keep all the patients in a particular place and we used to treat them. So because they demand 24/7 attention, they demand 24/7 medications, they demand a very much close care for fighting with the death and all. So that's how this concept of critical care medicine evolved. So keeping them in a particular place, knowing about the disease ailments, knowing about how to treat them, that made this medicine a special part, and that made a critical care medicine to evolve in this particular place right now, as of now, where we are right now. So coming to why it is unique compared to other fields, that's the next question which was asked. So it's definitely a unique field of medicine compared to all the sub branches. Critical care is a unique field of medicine here. Why? Because it demands your time, it demands your skillness, it demands your medicine. Apart from your routine medicines like a general physician, general surgeon, those knowledge should be there. So you should be a master of all. It's just like a director's job when it goes to a movie. So you should know all the 24 frames or how many frames, I don't know, but the number of frames in the movie should be known to the director. The same way, a critical care physician should know every branch which is involved or every part of the body which got damaged. So in a way, he has to balance the music, he has to balance the treatment inside the department of critical care. That's why it is very much unique. And also, it is very much demanding. So you need to have always 24/7 coverage for your patients. So with your life, you are giving life for the patients. So my teacher used to say me that by doing a night duty or by sparing a whole night's sleep, you are trying to extend the life of a person who is very much critically ill. So that's why it's very much unique, and I feel proud to be a critical care physician.
That's very insightful, sir. Thank you for sharing that with us. So, sir, the mental health is very crucial for critical care patients. So, can you address the available support systems that are available for the patient?
Yeah, that's a good question, Suparna. So, first of all, before going to answer that question, you need to understand why mental health issues happens to a patient inside an ICU. So if you can know the reason, if you know the etiology, then only you can treat it. If you know the reason, it's like cause finding and then effect treating and all. So let us see what are the various reasons patients do have mental health issues, the reasons for mental health issues inside an ICU. So patients are all clubbed together in a particular place. They are not supposed to see the light also. They don't know the circadian rhythm. They're not seeing the sun when the sun is rising or when the sun is setting. So they'll be completely disturbed in a single place, staying in a single place without knowing what's happening outside. Even I think I also will get mentally disturbed if I lock myself in a room for 3 or 4 days. So without doing anything, I have to just relax on my bed and then wait for the organs to get recovery, right? That is one of the most important reasons they'll get mentally disturbed. The second thing is they'll have a disturbed sleep patterns in different phases. And all my monitors will make slightest amount of sounds which will prevent them to go into a deep sleep. So their sleep is completely disturbed. So once their sleep is disturbed, again the mental health issues happens. The third thing is sometimes they'll get feared out of the dying patients. For example, I am sitting in this bed. A bed next to me had a collapse and crash, and then patient has died. He might be thinking inside his brain, "Acha, next chance is mine. I have to go. I am going to die and all." So this thought process we cannot stop rather than counseling part. So this also will go into mental health disturbances, and even some medications also come with some side effects. So we combine together all these things. We call it as ICU induced psychosis or ICU induced delirium. So which is most of the times it is inevitable. We can try to postpone it, but you cannot completely prevent. Someone who has got a prolonged ICU stay, more chances of ICU induced delirium do happen here. So how to tackle it off? So generally, as a critical care physicians, what we generally do, to just replicate the circadian rhythm. We used to switch off all the lights on the patient's head end during the night time. The minute it is 9 o'clock, I used to switch off all the lights on the patient's head side. So it's just like an indication for them it's in the night. And in the morning 7 o'clock, I used to switch on all the lights and all. That is the first thing which we generally do. And second thing is frequent communication. So if one sister is allocated, she will be frequently communicating to the patient so that no need to worry. It's like a consoling you. No need to worry, sir, you are improving. So just a good morning wish or a good evening wish will make the patient comfortable, to feel comfortable in the bed. And then third thing is taking samples when the patient is awake. Generally, the rounds in the ICU, the doctor's rounds start at 8 o'clock. So we expect the blood values, everything to be ready by 8. So if that should happen means you need to take the samples at 4 o'clock or 5 o'clock in the morning, wherein the patients in the deep sleep phase, we'll wake them up, sir, I'm going to poke you, and then we're going to disturb their sleep and all. So to prevent that, what we generally do is we used to take samples all at a time, and the patient is awake. It's not in their deep sleep, we'll make them awake and then take the samples and all. Sometimes we used to keep, if the frequent sampling is required or if the patient's condition is in such a way that we need to take more number of samples, we used to place something called a center line in the neck. So wherein without disturbing the patient, you can directly take the samples from the center line itself. So it will be happy for the patient, there will not be any sleep disturbances and all. Fourth thing is allowing the family, as I said. And in some ICUs, not in India particularly, in some ICUs they used to allow the gadgets too. For having their only mind, focused on a particular point. They can see the serials what they want. So they can see whatever the things that makes them happy, or it might be music therapy. They'll allow the gadgets inside the ICU so that they'll feel comfortable, they'll feel lively. That's the whole point in doing all these things. So by doing all these things, you can try to prevent to some extent. But the family's role is very much important here. If the family is very much strong enough supporting the patient attenders, the mental health issues which generally we face inside the ICU can be minimized a lot. But the family also requires a support. So you need to, I'm an ECMO physician too, just for an example I'm saying. If my patient is on ECMO, forget about the ventilator, is the next level of ventilator. If my patient is on ECMO, the family is also will be depressed, like, my patient is on ECMO, will he survive or not? Already doctor has given me very less number of chances. So in those situations, what we generally advocate, we will connect them to all the survivors of ECMO. So all the patients who got fought on ECMO, came out of ECMO, if they mingle, it's like, you should have a good friends to have a good, good vibes. The same thing here. So we will make them mingle with the patient attenders who has survived. So in a way, it boosts up the confidence of attenders, it boosts up the confidence of the family and then the patient too. That's how we used to tackle the situation. But it's again patient to patient basis. Sometimes patient will have psychiatric issues from the beginning itself. So in those situations, we have to involve a psychiatrist inside your hospital to come and have a personal one-to-one counseling. So what is his exact issue that can be addressed? So what I spoke till now is a generalized issues. But patients who are already psychiatric issues are there, you need to have a psychiatrist in-house to address those issues. So if he does not cooperate, it's very difficult for a